Good morning. Welcome and thank you for joining us for our Northern Light Health. Good Health is Good Business Zoom conference. Today's session recognizes Lung Cancer Awareness Month. Screening for lung cancer has always been a challenge. However, we have an evidence-based screening program that we want to be sure you are aware of. Screening is one important component for dealing with lung cancer, and prevention is certainly at least as important. We'll spend time discussing employer strategies for prevention, tobacco use prevention and cessation, and target use for prevention strategies. For this session, we do not have a COVID-19 update. Dr. Jarvis is available during this session to answer any questions later. Our panelists today are Amy McClary, practice manager of Northern Light Cardiothoracic Clinic at Northern Light Easton Maine Medical Center and leader of the Northern Light Lung Cancer Screening Program. Roxanne Dubé, public health specialist at Bangor Public Health and Community Services. David Spalding, senior program manager of Maine Health's Center for Tobacco Independence. Erica Caldwell, wellness manager at Chinbro. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Health. I'll be your moderator for the next hour. Before we get started, I will read our legal disclosure. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply to every individual situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. First up, we'll share an inspirational 4-minute video that speaks directly to diagnosing lung cancer early. Okay, well, it seems technical difficulties have got us on this one, but very inspirational. So, Amy McClary is our first speaker, and we'll focus on why early detection is so important. Amy?
Hi, good morning. Thank you for having me. So I'm here to talk about the lung cancer screening program today. So why is lung cancer screening so important? Lung cancer is the leading cause of all cancer deaths nationwide. Lung cancer claims more lives each year than colon, breast, and prostate cancer combined. Each year, more than 220,000 people are diagnosed with lung cancer, and out of that, 150,000 people will die from the disease. Here in Maine, our statistics get a little scarier. Maine's lung cancer rates are 30% higher than the national average. And then here in Maine, 75% of the lung cancer diagnosed is detected too late, and as a result, fewer options are available for treatment. It's not fully understood why the lung cancer rates are so high in Maine, but what we do know is that we do have a high smoking rate and a older population. So both of those factors do contribute into our higher rates of lung cancer. So this graph just is put out by the CDC, and you can just see where lung cancer falls compared to prostate, breast, colon, rectal, pancreas, etc. So you can really see that it does have quite, it has more diagnoses than all the other cancers. So what is the outcomes and statistics when we look at lung cancer? There is good news. Early stage lung cancer is curable. 80% survival is reported with surgery alone in the earliest stages. As I had previously stated, majority of the lung cancer is detected too late here in Maine, and most we see nationwide, most of it is diagnosed at a late advanced stage. The takeaways from this is that early stage lung cancer is treatable. And early stage lung cancer often doesn't have any signs or symptoms. That's why screening is so important. We do lung cancer screening with what we call a low dose CT. It's designed to detect cancers at an early, potential curable stage when patients have no signs or symptoms of lung cancer. So when we look at lung cancer screening compared to other cancer screening, there are several eligibility requirements patients have to meet to be eligible for this. So patients have to be between the ages of 50 and 80. If you're a Medicare patient, they only support screening through that 77th year. You have to be a current smoker or one who's quit within the last 15 years, have a smoking history of what is called at least 20 pack year. So that means, if you were a pack a day smoker for 20 years, that would give you a 20 pack year history. Or if you were 2 packs a day for 10 years, that would get you that 20 pack year history to be eligible for lung cancer screening. Show no signs or symptoms of lung cancer, such as coughing up blood, unintended weight loss, cough, shortness of breath, things like that. Um, and another important piece of it, especially coming into cold and flu season, is not having used antibiotics in the last 12 weeks to treat a respiratory or a lung infection. And that's important because we want to screen patients when they have healthy, we want to help, they're healthy, we want to establish a good baseline for lung health. So a little bit about our screening program here at Northern Light. Our program, we established it in 2014. I believe our first CAT scan we did that year was in July. To date, we've screened over 6,000 patients for lung cancer. We have what we call a hybrid program, meaning that primary care providers or other providers can talk to their patients about lung cancer screening, and then also order the scan, and then they would come for it. But also our internal primary care providers have the option of identifying eligible patients and referring them directly to the program. When they select that option, we have a nurse practitioner here that will see the patient, talk about the risks and benefits of screening. We will order the lung cancer screening CT, and then we'll follow that patient and order any additional workup that might be needed. Over the years, we've started partnering with our other Northern Light members to offer the low-dose CT locally, but to have the data tracking and surveillance done by Eastern Maine Medical Center. So what that looks like is if you go to your local Northern Light hospital, they'll do the scanning, but we take care of all that surveillance piece. So those reminder letters that go out to the patients and providers are generated here at Eastern Maine Medical Center. And most recently, we were awarded the Center of Excellence for Lung Cancer Screening by the GO2 Foundation. So as we started our program back in 2014, we've seen significant growth over the years. Last month was a record-breaking month for us when it came to lung cancer screening. We did over 450 screening CTs. We spent a lot of time over the years educating the community and primary care providers about the importance of lung cancer screening, so there's more awareness about it now. We've also seen some guideline changes over the years that have expanded the eligibility for lung cancer screening, making more patients eligible for this life-saving exam. So since our program started in 2014, up until July of this year, this is what we've detected for lung cancer is through lung cancer screening patients. You can see over 60% of these patients were diagnosed with early stage lung cancer, giving them the best chance of survival rates. But unfortunately, we still pick up a fair amount of late stage disease with lung cancer screening. And again, these patients had no symptoms at presentation. So it just shows you how advanced and how quickly this disease process can spread without having any symptoms. Our cancer detection rate is right around 1.5%, which really falls in line with what we see across the nation as well. This is a slide we go over often with patients when they come to us for lung cancer screening. I think it's a really important fact to note that 50% of people have lung nodules by the age of 50. And by no means does that mean it's a cancerous nodule. I tell patients all the time, you know, as we age, we develop lumps and bumps and aches. Well, our lungs develop lumps and bumps too. This is why screening is important, and it's important to come year after year for your screening. It's not a one and done. You know, we look at these nodules year after year, making sure they're not growing, that they haven't changed in their characteristics. So it's really important. And it's important to note that not all lung nodules are cancerous. Oftentimes, these small little ones, we just watch them and they amount to nothing. A 5 mm lung nodule is approximately the size of a pea. If it was something we found on your CAT scan, the recommendation would just be to come back next year and we'll do it all over again. We'll look at it to make sure it hasn't changed. Nodule that's 6 to 8 millimeters, so just a little bit bigger than a pea, is still considered benign. Depending, you know, if it's closer to that 8 mm mark, we may have you come back in 6 months just to make sure that it's stable and it's not changing or growing. But if it's deemed stable, we'll have you come back in 12 months for another screening. A nodule over 8 millimeters, the size of a cherry, is considered suspicious for lung cancer, and further testing or referrals to a specialist will be done. You know, sometimes it's coming back in 3 months for another CAT scan. Sometimes we go to PET scans, but it's something, you know, we'll work up to make sure that's nothing to be concerned of. The most helpful thing patients can do to reduce their risk for lung cancer is to quit smoking. It is certainly not a requirement to participate in lung cancer screening, but you can see that there are benefits even 20 minutes after quitting smoking that, and they'll carry through for the next 15 years. Patients will continue to see benefits. We welcome anyone to call us at our program if they have questions about lung cancer screening, and then there are some helpful websites over there as well.
Well, thank you, Amy. Next up is Roxanne Dubé, who will talk about tobacco use in youths and targeted prevention strategies. Roxanne?
Yes, thank you, Dr. Gilkey, and thank you for the opportunity to share today. This first slide we're going to look at is a data point that is part of the Maine Integrated Youth Health Survey. I started this work in 2017. This was a question on the survey that asked high school students in Maine who reported any tobacco product use, including e-cigarettes, in the last 30 days. And that number was 29.6% in 2019. Down in the middle there, you'll see those that reported using an e-cigarette was 28.7%. Now, when I started doing this work in 2017, that same number was 17.5%. So there was a really big jump in just 2 years. In Penobscot County, where I do my work, that number was 14.6% in 2017, and it jumped to 26.2%. We saw this as a national trend. It did follow the same trends nationally, and the Surgeon General actually issued a report and called e-cigarette use for youth an epidemic at that point in time. The latest data that was released is 2021, but I bet you'll imagine that due to COVID, there might be some gaps there. I know in Penobscot County, we did not have enough schools responding to have county level data, as what a number of other counties saw that too. And the data for 2023 should be released in early 2024. So my next slide, we're talking about lung health today. And while these products share some commonalities with cigarette smoking, there are also some differences. A lot of times I have these products referred to as harmless water vapor, and even some of the marketing around them has implied that they are a vapor. In fact, they truly are more what we would call an aerosol. And how I explain to students that I work with to figure out what that means, I ask them to imagine standing in a hot, steamy shower and taking in a deep breath. That would be an example of breathing in water vapor, which will eventually mix with air and disappear. Breathing in an aerosol might be an example of standing around and spraying bug spray all over yourself in the spring to avoid the black flies and breathing that in. They are very different experiences. Another difference with these products compared to smoking is they create a very ultrafine particle in that aerosol, even smaller than the smoke particle from a combustible product like a cigarette. These smaller particles are able to travel farther and deeper into lungs. And as I mentioned, this is an aerosol that's traveling into the lung tissue. And we do see a disturbing trend with students who are using these products, attempting to hide usage, and they will actually take a puff and hold that puff and let out very little exhale until the product dissipates throughout the lungs. And this has a nickname. They sometimes refer to it as stealth mode or zero. So again, some lung concerns there for sure. The other thing I want to point out here is during that epidemic period of time, something changed with nicotine. The nicotine prior to 2016 was what we would refer to as free-base nicotine. In 2017, a process created something called salt-based nicotine. The concerns with the salt-based nicotine is it allows much higher concentrations of nicotine into products, some of the highest levels we've ever seen in any products. And just so you know, the United States does not currently regulate nicotine levels in products at all. So there doesn't seem to be a top bar. The concern with the nicotine is it is highly addictive. And with very little experimentation and the higher levels of nicotine, there is more risk for dependence and addiction. Also, a deeper dependence and addiction is possible. And those most vulnerable are the adolescents, as they are in a place where their brains are still developing until about the ages of 25, 26. The next slide is the other piece of what happened during the epidemic is these products no longer resemble typical tobacco products. And I find a lot of responsible, caring adults don't recognize what they are seeing. If I were looking in the bottom of a backpack and taking out the squashed peanut butter and jelly sandwich that was left there, I may not recognize that there are actually a number of e-cigarettes in this backpack, along with the other school supplies. And I would say, you know, this is just one example. This fall, we saw a product that resembled a highlighter that was definitely not a school supply and was actually an e-cigarette. So part of the work we do is to educate parents and caregivers as to what these products currently look like, what they should be aware of. Next slide. So the work that we do with our schools is very multifaceted. We really help schools figure out all kinds of different pieces to work around this issue in their schools. One of those pieces is to connect them to curriculum. When I first started doing this work in 2017, there was not a lot of curriculum. Currently, I have over 20 evidence-informed, evidence-based curriculums that I can help schools connect with. They can be in person, they can be virtual, or they can be a hybrid model. Two examples here are You and Me Together Vape Free, which is a curriculum grade-based from Stanford. It is from their tobacco prevention toolkit. And on the right, the Be Vape Free is from Catch My Breath, another evidence-based curriculum option. These two programs would be considered universal prevention, which would mean their lesson plans are so that every student at that grade level would get this information. The other piece that we do is we work with schools to make sure that they have connections to My Life, My Quit, which is a partnership with National Jewish Health and the state of Maine. It is free, it is confidential, and it is evidence-based for 13 to 17-year-olds. And we want to make sure that our school nurses, our school-based health centers and everything that would lead students to a great option to quit would be available. So we provide training, all that good stuff, so they know how to make a referral. They have resources in print and other things to highlight the program. And what I like about this program is there's actually a parent component for parents looking for information about these products. And there's also a school component. This can be used as a targeted intervention, or what we would call an alternative to suspension for students who violated the tobacco policy. And that's what I brought today. Happy to take questions later.
Okay, thanks, Roxanne. Our next speaker is David Spalding. He'll talk about the link of cancer to tobacco use along with prevention and cessation strategies. David?
Thanks, Ed, and I'm happy to meet with all of you today. First, I'd like to say that I have nothing to disclose in terms of relationships with tobacco companies or medication companies. So I'd like you to join me in imagining this. There is a big, important problem, and people with this problem would like help with it, but they don't know where to get it. And you would like to help them, but you don't know how. And in the meantime, a lot of people with this problem are suffering, and some of them are even dying. But at the same time, there is help that's available, and it is easily accessible. It's effective. It's free, right? A lot of the people who get this help get better. And almost all the people who got the help liked it so much, they would use it again and recommend it to family and friends. And you could connect a person to that help very quickly, less than a minute. And it's really easy to learn how to do that, how to connect people to that help. That sounds like a pretty good deal, right? So what is this big problem? Well, it is tobacco use. Tobacco use is the leading cause of preventable illness, injury, and death. It's a chronic relapsing condition, and in terms of economics, it costs hundreds of billions of dollars in healthcare expense and lost productivity every year. Of course, it doesn't make cancer any better either. So why is this such a big problem? Well, nationally, it's a big problem. In Maine, about 1 in 6, almost 1 in 5 people use tobacco. And most of those people who use want to quit. 7 out of 10 are thinking about quitting. And about half of folks who use tobacco make at least one quit attempt every year. The bummer is that most of those quit attempts are made without any help, 9 out of 10 or more. And that only works about 3% of the time. Most unassisted attempts fail. Another way of saying that, more than 9 in 10 unassisted attempts fail. So my team at the Center for Tobacco Independence works with clinical care teams and others seeing patients in doctors' offices and hospitals and school-based health centers, et cetera. And we address some barriers. We found when we talk with providers and clinical care teams that a lot of times they don't really understand the dynamics of becoming addicted to nicotine and trying to quit. They have some misunderstanding about how treatment works, if they're even aware that treatment is available. And so we work to confront these misconceptions and correct some of their erroneous thinking. And we also train folks how they can make referrals to the Maine Quit Link, which is the state's treatment program for adults that we operate on behalf of the state of Maine, and also to My Life, My Quit, as Roxanne was describing, the program for youth. Why is this a great opportunity? Well, 4 in 10 people who use the Maine Quit Link to help, quit tobacco, they succeed. It's not 10 out of 10, but it's way better than 3 out of 100, right? And the program is free, no matter what you've heard. It has never cost a dime for people to get the free coaching, counseling, and medication. And as I hinted earlier, about 95% of folks, every time we do an evaluation, say that they would use the program again or recommend it to family and friend. And remember, not all those people quit successfully. So we think that that's a pretty ringing endorsement. So my team promotes what we call brief interventions. It's this ask, advise, refer model so that they can talk with their patients very briefly about their tobacco use and make a difference. So ask is screening if they use tobacco, how often, what type, advising, you think it's important that they quit, and referring, there's good help available. You could get in touch with them to learn how it works, and maybe even get that coaching all free. The CDC describes this brief intervention model. At first, they used to call it the 5 A's to make it easy to remember. And then they changed it to 2 A's and an R, ask, advise, refer, to make it even easier. And so that's where this fits in. This brief intervention is the first step in evidence-based tobacco treatment. Once you connect them to a program like the Maine Quit Link or My Life, My Quit, then the trained and nationally certified staff people there will work with your patient on developing a plan to quit, how they're going to use medications, and they'll provide ongoing support, especially important after the person has quit, after they started their quit process, to prevent relapse, because so many people do relapse. So the benefit, again, of brief intervention is that it can be done very quickly, 10 seconds, maybe a minute if the person actually accepts the referral. And it shows that you think it's important. And research shows that if a patient believes that their care team supports their effort to quit, they think it's important, they are twice as likely to quit successfully. So when you offer the referral, if you could jump back, Felicia, if you offer referral, it may result in a referral. They may accept it. And if they accept it, they may enroll in treatment. They might. And if they enroll in treatment, they're more likely to quit. But even if they don't accept the referral, you've increased the likelihood that they will make quit attempts. So there's really no downside here. So again, this is the part that can be played in seconds. The rest of treatment can take, weeks. The best practice is to get a number of interventions and use medication for 12 weeks or so. And the way we train this is also brief, because it'd be a little absurd, right, to take hours to train something that I'm saying you can do in seconds. And so it's a 30-minute presentation. We give about 15 or 20 minutes of content and have time for Q&A. And we just cover a few things. It's really important to address tobacco. Here's how you can do it very briefly. Here's how you can make a referral and have confidence. And so it's this simple 3-part message. And when you're connecting patients to the Quit Link, you're connecting them to nice people like Melanie here, who are nationally certified in tobacco treatment. And this is not a hotline. It would be useful for me if you would refer to it as the Quit Link and not the hotline, because it's not just call them day or night and they can talk me off the ledge and keep me from smoking this cigarette. It's a program that people enroll in and participate in over time, a few months if they do the whole thing. And this counseling can take place over the phone, which we've done for 20 years, or it can happen online or via text. And people can access free medication upwards of 12 weeks, depending on which program they pick, either the phone or the online program. And so people could learn more about this at mainequitlink.com. They could learn about what it's like to try to quit tobacco and the treatment options. There are also resources there for the public and for providers. And as Roxanne said, importantly, we do have this youth program. 95% of people start before they turn 26. Most people start when they're young. Importantly, if people are still using tobacco after 21 months, they begin to lose hope that they will ever quit. So it's really important to intervene early. And so we're really happy with this program. And so that is what I hope to present. And I wonder if you'll have some questions at the end. Thank you.
Great. Thanks, David. Our next speaker is Erica Caldwell, who will share ideas on an employer approach to promote lung health and wellness. Erica?
Yes, good morning. Thank you for having me. Good health is truly good business for Chimbro's employee owners. And the number one thing that we promote with our team members and our spouses with regards to good health is getting that all important annual physical with biometric measurements. We feel that this is so important because we know that doing this can help detect health issues earlier when they're often easier and less costly to treat. And along with that, we encourage team members and spouses who are tobacco dependent to use this time with their doctor to discuss the use of tobacco cessation products as a tool to greatly increase their quit success. And managing healthcare costs helps the team member and company control expenses. We have a little bit of a unique business model here at Chimbro where we are self-insured on our medical plans, and we're also employee owned. And so if we proactively manage our health and our healthcare costs, then we can increase the profitability of our company, which ultimately impacts the retirement savings of our team members through our employee stock ownership plan and profit sharing. So some of those incentives to be healthy are baked right into our business model. And those team members and spouses who do complete that annual physical with the biometric measurements, they will benefit by having reduced medical premiums. We also, as our other wellness programs, we do offer free tobacco cessation products, no cost health coaching, fitness and weight loss reimbursement, no cost mental health counseling, and no cost mental well-being app. And that is relatively new for us, and we'll talk more about that towards the end. We became tobacco free in 2003, so we've been at this for quite some time now. And we also made the move to prohibit possession of tobacco in 2010 as well. And, it just made sense that if we were going to be tobacco free, that our team members also didn't need the temptation necessarily of having those products with them in their possession at our facilities and sites. So we made that move as well. And we also do offer free tobacco cessation products. In fact, now under the Affordable Care Act, medical plans are required to cover certain tobacco cessation medications and products at 100% or no cost share to the insured under their medical insurance with their in-network pharmacy benefit. So what our team members and spouses do is they go to their annual physical, they take the form with them, and they use that opportunity with their doctor to have a discussion about cessation products, and their doctor may write them a prescription and they can take that right to their in-network pharmacy and fill that at no cost to them. And we also offer resources to support. Our employee assistance program is a free confidential benefit that's available to team members, dependents, and members of their household. And in addition to the mental health counseling benefits the program offers, it can also refer to smoking cessation programs and resources as well. And that's important, right? Because we have at peak 4,000 team members across 40 different states. And so it's important for them to have one place that can refer them to their local programs and resources. We are committed to ensuring the health and safety of our team. So being tobacco free certainly plays right into that. And this commitment includes our journey beyond zero. And so what that is we create an environment where not only are we preventing injuries, but our team members also go home in better condition than when they arrived at work. So we're looking for them to be healthier, more educated, and able to influence the people around them. And so, with that, our safety specialists on our sites additionally act as champions for wellness by continuously reinforcing the value of taking care of one's personal health and educating the team on weekly wellness topics. And so next week, we'll be talking about the Great American Smokeout, and that is through the American Cancer Society. And through that campaign, we'll be emphasizing with our team members that no matter your age or how long you've been smoking, right, you can see those benefits immediately. So that is really helpful and really resonates with our team. And because it can be pretty daunting, right, if they've been smoking for quite some time. We also share information on obtaining free tobacco cessation products, as well as additional resources to help quit. And finally, we reaffirm our commitment to provide a tobacco-free work environment to support team members in their journey toward living a healthier lifestyle. We also work with our medical claims administrator on monthly clinical campaigns for the month of November. The campaign is around smoking cessation. And that claims administrator, they are able to send direct mailings for us to those tobacco dependent members that have been identified through claims data. And this campaign strives to improve tobacco cessation and encouragement to seek support from healthcare providers. And then finally, just recognizing that, our being truly is a system, body and mind, each impacting the other. At Chimbro, not only are we looking out for each other's health and safety, but, it's really important that we're including our mental well-being as well. And with that, we're proud to offer Relax Infinity as an additional tool to support the mental health of our team members. And it's just another way to help our team members towards a healthy and tobacco-free lifestyle.
Well, thanks, Erica. All of our panelists will now join us on video for questions. Amy, I have a couple questions to start off for you. Early detection seems particularly important for lung cancer compared to other cancers. Why is that?
Great question. So that early detection for lung cancer is important because lung cancer can quickly go from a stage 1 to a stage 3. And also symptoms don't present until a much later stage. So sometimes patients just don't know they have it. So early detection is key. And more treatment options are available in those early stage cancers. As we get to those later stage lung cancer, there's just not as many treatment options available for patients.
So compared to other cancers, some cancers may take a couple of years to really go from one stage to another, whereas lung cancer may do that quicker. Is that the idea?
Yeah, I mean, it can happen even in just 6 to 9 months.
Okay, that's helpful for everyone to understand. A couple more for you, Amy. One is, what resources does Northern Light have for provider offices, such as patient handouts and et cetera? Is that something you can answer for us?
Yeah, absolutely. So the screening program has developed 6 different handouts to guide patients or to guide providers into having those conversations with patients. And we have 6 different patient aids that we use to talk to patients when it comes to lung cancer screening. Everything from the risks and benefits to understanding lung nodules to what that follow-up might look like if something was found.
So could providers' offices reach out to you for that direction, for that information?
Absolutely, we'd be happy to send them over.
Excellent. Thank you. One more for you, Amy, before we shift gears. So can someone who has never smoked be diagnosed with lung cancer?
Absolutely. We know that smoking is the leading cause of lung cancer, and that's why the criteria for screening is based off from that smoking history, but we know there are other factors that contribute to it, such as secondhand smoke, environmental or occupational hazards. They certainly can play a role in it, as well as just family history. But smoking is the leading cause, and that's why we see those guidelines for eligibility for lung cancer screening be based on smoking history alone.
And radon can play a role too, it seems, huh? And I think that's
Absolutely.
something significant in Maine.
Hmm.
Um, and to follow up for that particular person's question, there is some information about a family history of cancer. So, when you start talking about family history of cancer, it really opens up a lot of discussion. And there may be genetic components of it. It may be common exposures. There's a lot to that question. Um, and it's probably best to reach out, starting with the primary care provider, and start asking questions and get some direction and understand what you could do. Because I think you can gather that lung cancer screening eligibility wouldn't fall into anyone who never smoked. So that's a good case in point there. So
Yeah, and I think it's important to remember too, lung cancer screening's only been around for 9 years. So it's still a very new screening. Over time, I think we'll see these eligibility requirements expand. And we've already seen that, we've had several screening updates over the last, 9 years that have included more people. It's dropped the smoking history. But always be honest with your family care provider, have those conversations and see what testing options might be available for you.
excellent. Thanks, Amy. So David, I have a couple questions for you. So one is, I often hear patients state that NRT products, medications are expensive. You mentioned under PPACA, medical plans are required to cover certain products. Which products are these?
Well, so the fact is that nicotine replacement therapy like patches, gum, and lozenges can be expensive. They're not as expensive as the tobacco products that they're replacing, but they can be pricey, and they are supposed to be covered by insurance plans. Also, the other FDA-approved medications like Chantix and Wellbutrin are also supposed to be covered. That doesn't mean that there won't be a few hoops that people have to jump through to get that prescription filled, but they should be covered. But that's another reason why we think that Maine's program, the Maine QuitLink, is so handy, because it can provide FDA-approved nicotine replacement therapy at absolutely no cost and to the extent of best practice.
Excellent, thank you. Erica, I have a question for you. So this is probably reflecting Chinbro policy. Do you fire people for not quitting or for possessing tobacco products?
We have a pretty strict policy, progressive discipline policy around this. It's essentially a 3 strikes and you're out, because we do take it very seriously. But to be honest, it's really not, it hasn't been an issue for us recently. Certainly when we first started back in 2003, it was, but it's really all part of our culture. Um, and it has been for so long that being tobacco free is just really sort of natural. I would equate it to just putting on our hard hat each day, our safety glasses. It just kind of goes along with the territory that we just don't possess tobacco and use tobacco on our sites.
Thanks. So thinking about the programs your company offers, Erica, how receptive are your employees to those? It sounds like you've made a lot of progress since 2003.
Yeah, they are very receptive. Again, safety and health, it's what we do every day at home and at work, and our team members have come to expect these programs to support them in their journey towards living a healthier lifestyle. And, I would say that our health and safety culture is part of what really differentiates us as an employer. It's part of why people come to work for us. And it's also a big part of why they stay as well, because they do feel like they're well cared for.
Excellent. Thank you. So one of our participants points out that Northern Light employs 3 genetic counselors who would be happy to talk to patients who are concerned about a family history of cancer, particularly if early onset lung cancer with limited risk factors is present. So there's another resource for everyone on that. The next question is for Roxanne. So Roxanne, how do you overcome the sense of invincibility teenagers have as related to long-term health, particularly when dealing with tobacco use? You know, like they're invincible, nothing's going to hurt them.
Yeah, for example, the message that I shared with all of you who are tuning in expecting to hear about lung health today is very different than what we would present to a youth audience. Long-term and even in some instances, short-term health concerns just don't seem to be on the radar. And I think that's been the case for a long time. But what does resonate, we are finding, is there is a negative outcome for nicotine use and mental health. And young people really are very tuned in to mental health. So it is a way to open the conversation. And the other piece we do, I know I shared some data there, and when we talked about, while we thought those were high numbers and high jumps, if you turn that the other way around, you'll note that 70+% of students are not current e-cigarette users. So we point out the healthy behaviors and the other options. So what are those other 70+% students doing differently in dealing with stress and coping and those sorts of things? So it is a different message for sure.
Mm-hmm. I've sort of a related question. How does e-cigarette use compare to smoking from the perspective of the lungs? And wondering here if teens see it as safer, like e-cigarette use as safer.
Well, as I showed with the aerosol slide, I mean, the term vapes and vapor come from the e-cigarette companies. It is what they would prefer their products be related to or called to. And that's why when we do some speaking with audiences, we remind people that we want to call them by things you recognize. And a lot of times they are called vapes. But I like to quickly point out that, it is an aerosol. So they are different, as I mentioned, for smokers. Those ultrafine particles are much smaller, and there is a concern that they are able to travel farther and deeper into lung tissue, and what that looks like over time. And we also had the EVALI incidences, the e-cigarette and vaping associated lung injuries that happened just prior to COVID. And on our radar, we're seeing that while COVID sort of overtook everything for tracking and reporting, EVALI is still there and is still happening. So there's that concern with lungs as well.
Just Roxanne, just to fast forward, let's call it 20 to 40 years down the road, with teenagers using e-cigarettes, are you anticipating significant lung cancer related to that at that time?
Well, I am not a scientist. I do also do some work for a cancer grant. And in the past, we were not able to do e-cigarette work on this grant. And as of this last round, we are. So I do think there's some data that is indicating that very strongly that e-cigarette usage can lead to cancer down the road.
So I think the message of this is, no, it's not. It's only an e-cigarette. Great. Thanks, Roxanne.
Yes. Thank you.
Amy, a couple of questions for you. Low dose CT CAT scan. How concerned are you about radiation over years of screening?
So very little. So the way we do these low dose techniques or these CTs, they actually use 75% less radiation than the traditional CAT scan that you would have if you had symptoms or pain that they were investigating. And when we compare that to like radiation in our everyday lives or from chest x-rays or mammograms, it's quite little compared to a full dose CAT scan. So there's very little concern about the radiation exposure because this yields so many results.
Mm-hmm. Okay, so that's a risk benefit ratio that favors the benefit.
Absolutely. And that's why, with lung cancer screening, it's best for patients to have a conversation with their health care provider about these risk benefits.
Mhm. Okay, great. Thanks. That's helpful. Does secondhand smoke exposure count towards eligibility for lung cancer screening?
Unfortunately, no, at this time, eligibility is all based off from that personal smoking history.
Mhm. Okay, so that's important to understand. Great. Well, thanks. David, does cutting back lead to quitting? And how about cold turkey? So I think those are some concepts that feed into your 3 out of 100 are
Right.
successful on their own, huh?
Yeah, that's a great question. So, right, cold turkey or unassisted hardly ever works, and it's the most commonly used approach to quitting. And so we try to dispel, that and make people aware that medications and coaching can really make a very big difference. As far as cutting back goes, what the research indicates is that people who try to quit by gradually cutting back end up just being continuing tobacco users at a lesser rate. So it's not a very often effective way to quit. More recently, though, in tobacco treatment, there's been a trend towards accepting what we call mini quits, where people, just try not to use for a day, try not to use for a weekend, see how long you can go. That's what, just feel what it's like. Try the medication, try the patch for a day and just see how that works. And there is reason to believe that mini quits can lead to eventual success, quitting for good.
That's good to understand. So
Mhm.
that leads into a logical next question. Do most people require a medication to quit?
Well, I guess it depends on what you mean by require. Certainly, most people who don't use medication don't quit. That's just what the statistics bear out. Um, but some people can't use medication. For some people, there's a contraindication that would make using the medication, not in their best interest. It's rare, but it could be the case. And so, just getting coaching without using medication can also greatly improve a person's chances of quitting.
So I think my takeaway on all of this is it's a hard thing to do alone. You need to get
Mm.
some help.
Yeah, the numbers in terms of how addictive nicotine is stack up very closely to opioid addiction. It takes many, many, many attempts to try to quit before most people find success. And that can be a little disheartening and counterintuitively, because with each successive attempt, you're more likely to be successful, but people can get discouraged. And that's why we want healthcare providers and others to encourage people to keep trying.
What would be a typical story of a person? How many times do they try to quit?
Oh my gosh, I'm a little reticent to say. We often advise clinical care team members not to say this to a patient, but the most recent research suggests that the average number of attempts when researchers surveyed people who use tobacco regularly and quit successfully, how many times did you have to try? The average was 30. So some people fewer,
That
some
really
people
is
more.
remarkable.
I would just say, it's not unusual for it to take, many attempts.
Mhm. It's interesting. In my training as a physician, um, it was really driven home that every time I have an encounter with a patient who smokes, I should encourage them to stop smoking. And that feeds into the 31st time on average you'll be successful in helping a person.
Dr. Gilkey, the National Cancer Institute has made quitting tobacco the fourth pillar of cancer care, along with surgery, chemotherapy, and radiation therapy. And they advise exactly that, to intervene with each patient who uses tobacco at every visit, because it is so useful. Even if they end up not accepting a referral, it's more likely that they will make a quit attempt.
Mhm. Well, thanks for that. Erica, do you have a differential health plan premium for tobacco users? And if you don't, has that been discussed amongst the management team?
Yeah, so we did previously have two different levels of wellness credits. One level was for just getting your annual physical with the biometrics, and then we had an additional level for meeting certain criteria. And one of the areas that could help you meet or qualify for that additional credit was being tobacco free. Um, but we saw that there were quite a few team members who were choosing just not to even engage in the program at all or submit for the first credit because they knew they wouldn't qualify for the second credit. So we decided to, a couple years ago, just kind of simplify the program and just put all our eggs in one basket, if you will, and make the entire credit available for just getting the annual physical and biometrics alone. We were really concerned that there were people, especially due to COVID, who just weren't even seeing a doctor once a year
Right.
for an annual physical. So we said, you know what, let's focus on everyone sees a doctor, and then if they do that, they'll get the credits.
Mhm. Okay, good. That's good to understand. And do you use financial incentives to quit?
Not specifically in a sense, yes, just because again, with our business model, we're self-insured and employee owned. And so, we just educate our team that if they proactively manage their health, then this will ultimately impact their retirement savings. And we just really try to, have that culture where we're all pulling together to not only look out for our own health, but also the health of our fellow team members and just being able to really help one another and support one another.
Mhm. And part of that help includes the mental health counseling that you mentioned in your slides.
Yes.
Could you talk about the timing? Who does the counseling, or is it outsourced in some way?
Sure. So the counseling it's available through our employee assistance program, and that's with Cigna. And Cigna utilizes their behavioral health network for both in-person and virtual appointments. But I will say that we share the nationwide challenges of provider availability when it comes to mental health counseling. So that's definitely a challenge that we're looking to see improvement on in the industry.
Yeah. Yeah, well, I think there's a lot of challenges related to mental health in our country for sure. You know, okay, well, thanks for that, Erica. I have a question here. Would Northern Light Health consider a stricter policy around smoking similar to Chinbro? And I would say that we're going to forward that question on to the people within Northern Light Health that would be in a better position to answer it. They're not on the call today at this session. So great question, but I don't think we'll try to answer that currently. Roxanne, is vaping the same as e-cigarette use?
Yes, as I mentioned, the e-cigarette companies like the word vape associated with their products because it does imply it's safer, like a water vapor. But they are the same products. I will say there's about, at last look, over 450 different types of products that would be considered e-cigarettes on the market. And that's a huge number. And like some of them look like highlighters and other office supplies. So you just never know, but they are all considered e-cigarettes and they all produce an aerosol.
Hmm. And then I'll just follow up with one other question for you, Roxanne. Are the various forms of tobacco equally addictive?
Um, I would say when we look at sales data and what's going on currently, what we are seeing are products that are using the newest formulation, which is salt-based nicotine. And as I mentioned, I would say e-cigarettes, we're also seeing, you may have seen the pouches that look like that, well, look like a canister similar to a breath mint, and there are also some mints that are coming out, and the nicotine levels in those are not being regulated. There's also, so they're very high with the salt-based, and there's also, to avoid regulation, a lot of companies are selling things, products that they say are tobacco-free, which is very misleading because those products still contain high levels of nicotine. The manufacturers are claiming that the products are synthetic nicotine. They had done it to avoid regulation. The regulation has caught up with that, so that any product that has nicotine derived from any source, synthetic or tobacco, is still considered under regulation. So a lot of confusion there, but products now are high nicotine concentrated.
So Roxanne, I'll just stick with this thought for one minute. So nicotine probably is the driver of the addiction, and it's probably dose related. And secondly, all the other stuff that's involved in smoking and vaping, et cetera, are contributors to cancers. Is that correct, what I said?
We can't really, e-cigarettes have only been on the market for a relatively short period of time research-wise. So that's why I'm reluctant to say that they directly lead to cancer, because I think there's some scientific evidence that's pointing in that direction, but I don't think it's definitive. Whereas with cigarettes, which contain 7,000 different chemicals, 69 of them we know are cancer causing. That's a whole different story. And the e-cigarette issue, originally it was designed as a quitting option, but what we find tends to happen is what we call dual use. And then we're seeing patients with the dangers of tobacco plus the unique and different dangers of e-cigarettes combined, which creates another potential health mess. So we really try to discourage dual use for sure.
Well, thank you for that. And I'll wrap that up by saying David Spalding shared with me that nicotine is known to cause lots of damage to brains and other parts of the body. So we can't take that lightly at all. So we've reached the end of our scheduled time. We have included resources for you at the end of this presentation. Thank you all for joining us, and thank you to our panelists for great ways to enhance healthcare for people while decreasing. I hope this hour will help you to successfully influence the people in your business. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be on December 14th. Our topic is wellness strategies to support employee mental health. We are all acutely aware of the importance of mental health, and I hope you will join us. We will send you the link for this session. We encourage you to share the invitation with your friends and colleagues. By working together to promote good health, we will be promoting good business. Thank you and have a good afternoon.